All right, so threats to pain, rest, and sleep. Here are your objectives. We want to talk about and know the difference between acute and chronic pain. We want to know the difference between somatic, neuropathic, nociceptive, and visceral pain. We want to know what the characteristics and some examples are and what our treatment choices are. What's an adjuvant analgesic? Something that works with the another one, right? So like when we talk about the different medications, sometimes for neuropathic pain, not only will we use, someone who has a spinal cord injury, maybe we'll have them on some pain meds, but then we'll also have them on something like gabapentin or something for the neuropathic pain. So they're meds that we use with other medications that work well together. Non-pharmacological pain and symptom interventions, relating the consequences of untreated pain. And I know that you guys talked about that, I think, in level 2 when we talked about some pain and sleep and the difficulty if you have pain. Recognize the difference in client perception and response to pain. Assess your client need for administration of PRNs. Recognize clients' rights to pain management and describe cultural responses to pain. So tell me the difference between acute pain and chronic pain. Right, so acute pain is new, chronic pain is ongoing, but usually they say, what? 3 months. Usually it's 3 months, greater than 3 months for chronic pain. So that being said, acute pain can turn into chronic pain, correct? Acute pain can be from many different types of situations. Sudden trauma. You might have acute pain that turns into chronic pain. Acute pain can last for hours to weeks. It can be caused by surgery, trauma, medical procedures. It can be mild, moderate, severe. And a lot of times when we prescribe pain medication, we prescribe, such and such dose for mild and then such and such dose for moderate to severe. So we depend on the patient, because remember, the patient, whatever they say their pain is, that's what their pain is. With acute pain, usually the prognosis is predictable. So if you have surgery and I'm your orthopedic surgeon, I can tell you what most people, right? Because not everybody is going to react exactly the same. But I can tell you what the course of the pain usually will be, how long you'll have it, when it'll start getting better, when it will suddenly turn to nerve pain, and when it'll go away, right? When we talk about chronic pain, it's defined as lasting greater than 3 months, and it can be months to years. It can be disabling. Often it's seen with anxiety and depression. The prognosis is unpredictable. So when we talk about classifications of pain, we have nociceptive pain and neuropathic pain. So nociceptive pain is your pain from somatic and visceral. So what does somatic mean? What is somatic pain? So that's like your sunburns, right? Skin pain. Visceral pain is more your organ pain. And then neuropathic pain is something coming from the spinal cord. I just said that. So nociceptive pain can be deep, aching, throbbing, bone, joint, muscle, connective tissue, so sunburns, tendinitis, appendicitis, pancreatitis. When we talk about neuropathic pain, it's usually, what's the word that people usually use to describe neuropathic pain? Burning, shooting, right? It's usually like a burning, shooting pain. If any of you guys ever pinched a nerve in your back, you get that pain that goes down the leg, like the sciatic pain. What else can cause neuropathic pain, not just pinched nerves? Diabetes, so can cause the neuropathic pain. Post-herpetic neuralgia, so those are your patients that had shingles. What about patients who have had amputations? Phantom limb pain is actually neuropathic pain. So usually when someone has phantom limb pain, Something like gabapentin will help with that. So these are our pain assessment tools. We have lots of them. So it's our 5th vital sign. We in the hospital use the 1 to 10 when we go in and we ask a patient about their pain usually. If it's someone who maybe can't talk or doesn't understand as well, we might use the, let's see if I have the picture on here. The little faces there, the Baker Wong Baker. Identifying characteristics. So when you're asking someone about their pain, have you guys ever been taught like a mnemonic to ask about pain? What is it? PQRST? I was always taught old cart. So, but this is the same thing, right? You want to know the onset, the location, the duration. Is it radiating? Does anything make it worse? Does anything make it better? Basically, have you taken anything? Subjective. So your patient's going to tell you, answer all those questions that you just asked. That's all your subjective data. Your objective data is he's laying there, he's grimacing, he's, you know, sensitive when I touch his right arm. There's just the other pain rating scales. So treatment for pain. So it's pretty much a holistic approach, right? So every patient deserves pain treatment. What if you have your patient that comes in and you're getting a report and the nurse is like, oh, he's just a drug seeker.
Still have to treat the pain.
You're still treating that patient's pain and you're taking their word for what it is, right? Or the patient maybe came in and said they weren't any pain meds at home, but now they want a whole lot of pain meds all the time and they're tolerating them really well. I'm not there to detox a person in the 3 days I might work with them at the hospital. I'm going to do, you know, if I have doctor's orders saying that they can have their morphine every 2 hours and they can have, 10 milligrams or whatever every 2 hours, that's what they're getting, right? So it's not my job as a nurse, when I'm working as a nurse at that hospital, to say that I don't think that person needs that many meds because he was just in his room giggling, talking on his phone. That's not your job. Job is to treat the patient, and whatever the patient says, I mean, you're obviously, if you only have an order for every 4 hours for pain meds, you're not going to give them any more often. You're not going to give more than they are ordered. And if you truly think there's a problem, you're going to talk to the physician, and then they'll go in and talk to the patient and change orders if they need to be changed. They can do therapeutic nerve blocks. Has anybody ever had one? Did they do it while you were awake under fluoroscopy? And it's pretty painful, right? Yeah. The thing is, they grow back, so you have to get them done every year or two. So those are cases where you've tried everything. Patients had, MS Contin, they've ended up on methadone, and there's nothing that's really touching it, and it's nerve pain, and it's unbearable. They'll go and they'll do the nerve blocks. Physical therapy, so acupuncture. I was never a believer in acupuncture until my back goes out every 2 years or so. All of a sudden, I'm bent over and I have an ice pack and a TENS unit, and I can't stand up straight. So that happened one semester, and it was during nursing care management, and I was at Northside, and I had students on 3 different floors. And usually at Northside, I just run up and down the stairs right there because it's easier than walking all the way back down to the elevator. So I'm like there one day, and I'm all crouched over with my TENS unit and my ice pack, and I'm like, oh, I gotta go around to my patients, then I'm gonna go over. We get free chiropractic care here. Did you guys know that?
We as in us?
Yeah.
Where?
And I know everybody. I'm always surprised that you guys get this far and don't know this. At the NUHS clinics, there's one here in the building, and there's one on 72nd. So not only you, but your significant other gets free care, and they do acupuncture and all sorts of stuff. Yeah. So I know. I don't know. They should tell. I'm sure they tell you this in orientation, but you're just like totally overwhelmed, probably. So anyway, so I go to see my patients, then I go to my go to my chiropractor. So I get in there, and she's like, oh, you're in too much of a spasm. I can't do anything. I can't adjust you. If I touch you, you're going to spasm more. I'm like, I know, but I need you to do something. And she said, how about acupuncture? And I was like, whatever. Yeah, sure. Let's try acupuncture. I crap you not. The next day I was running up and down the stairs at Northside. Like, never believed in the acupuncture until it actually, worked. So, do any of you guys get acupuncture for stuff? A couple of you?
I've had it.
I love it. Did it work?
Mm-hmm.
Yeah. I don't know, it's amazing. And I think they charge you $2 here because you have to pay for the needles. But there's a community acupuncture downtown where it's like sliding scale. You pay what you believe you can pay. So you can pay like $5 or $10. Exercises. So, if a patient has a bad back and they're always having back problems, that's one of the things that they always try and do is probably get that core tightened up for the back, right? So we're going to encourage them to do certain exercises to tighten up the muscles. They're going to help with whatever's going on. Heat and cold, we don't need a doctor's order to do that, right? So your patient's in a whole lot of pain, they're not due for their meds yet. One of the things that you can do is heat and cold. You can also reposition, guided imagery, which most of us don't have the time to sit there and do guided imagery with our patients, but it's one of the things we can do without an order. Relaxation exercises, we can dim their lights. A lot of units now have the little diffusers. We can put diffusers in the room. On the hospice, there's always diffusers in the hallway and stuff. We diffuse the heck out of people. It's true. Adjuvant therapies. So the adjuvant therapies, again, would be like your gabapentin. What are some other ones that you guys have heard about that we use for different things? Most of the time it's for neuropathic type pain or headaches. Right, so Cymbalta, Lyrica, that class of drugs. Baclofen, I'm like, where did that come from? Yeah, so baclofen is like an antispasmodic. We'll use the tricyclic antidepressants. So Elevil, well, what are the generics? The nortriptyline, amitriptyline. We'll use those along with opiates to kind of help along. Why do we give, instead of just giving oxycodone to a person, why do we give them Percocet, which is oxycodone and Tylenol? So yeah, we can get them better, and I'm sure that's what half of you just said, but like I didn't hear much. But we can get them better pain control with a lower dose of opiates, because really we don't want to give somebody 30 milligrams of oxycodone, right? So if we can get the same, giving them some acetaminophen along with 5 milligrams as we can with just 10 milligrams of like oxy-IR, then we're going to do that first. So that's why we have those drugs, but then we have to watch where we can't give them too much, because what's our ceiling for Tylenol now?
8 grams a week.
So it was 4, they were saying, but now they're saying closer to like 32, right? Is that what you guys usually do at the pharmacy, like 3,200? So if you have a patient who's taking a whole lot of Percocet, sometimes we'll have them on Percocet, which has that acetaminophen in it. And then for breakthrough pain, instead of giving them extra doses of Percocet, we'll give them just the oxycodone, depending on how much they're taking, once we've reached that ceiling. One of the other things that we use a lot of are patches, right? Like lidocaine patches. Some people love them, some people hate them, they say they don't work. But we use lidocaine patches a lot. This is just a little flow chart saying that if it's somatic or visceral pain, we will start off with NSAIDs or steroids, right? Because we don't automatically, you don't come into my office and say, I don't know, my knee hurts. And I'm like, all right, here's some Percocet, right? Maybe in a hospice I do, but not in normal world. And so you're going to come in, the first thing I'm going to do is probably put you on a leave 2 a day, or give you the naproxen, twice a day for 2 times a day for the inflammation. And I'm going to say, come back and see me in 14 days if it's not any better, or 7 days if it's not any better, right? And then maybe I'll add in a steroid if it's still not, and then we'll go to the opiates. And then maybe sometimes we'll add in like the baclofen or the Flexeril, and then there's tramadol also. As far as the neuropathic pain, that's when we have our anticonvulsants like the gabapentin and the antidepressants like the am I saying that right? The amitriptyline and Yes. That we add on for that neuropathic pain. Yeah, they use Lyrica and Cymbalta also. Side effects. Tell me some side effects of medications in general.
Nausea. Constipation.
Nausea, vomiting, GI upset, dizziness. Especially with our pain medication, we get a lot of constipation. Someone said dry mouth. So which one of all those sticks around? Constipation. Most of the rest of them will dissipate in the first couple weeks. So if a patient after the first couple weeks is still really having issues with some of the side effects, we'll change the medication and see if there's something else we can use if they're really having issues with it. Hopefully the wrong thing to do is then start adding medications to treat the side effects of those medications, because then we just run into problems. But that's definitely a huge reason why treatment failure happens, especially when we start talking about the very last lecture I give to you guys is HIV. And so when we talk about medications, then there's a huge, and it's not as bad as it used to be, but the treatment failure used to be really high because people would stop taking them because the side effects were horrible. So what we need to do is a lot of education with our patients. Does anybody actually read the little inserts that come with their medications? You do? We probably are more apt to than the general public, right? Unless it's like my grandma, because she reads everything. But, you toss them away, but a lot of times we want them to know if, these are the most common side effects, you have to let me know if you're having them, or these are the ones we definitely don't want happening. And we want to make sure that our patients are reporting that back to us so that we can take whatever measures we need to so that we don't have treatment failure, so they don't just stop taking them. Untreated pain, I know that you guys, like I said, talked about this a little bit, only because I taught the LPN process for a couple of summers, and that was one of the lectures that I did. So untreated pain basically is going to lead to not sleeping. It can lead to immunosuppression. It definitely leads to anxiety and depression, psychosocial dysfunction. It just basically, even if it's acute pain, it's definitely going to lead to chronic pain if it's untreated. So we've all seen that patient that we go in and they're like, no, I don't need any pain meds, and they're like wincing in bed, right? So a lot of times the patients have this preconceived notion that, and we have hospice patients, honestly, that I got a call I was on call from 9 a.m. Sunday morning to 8 yesterday morning. So at like 11:30 Sunday morning, I get this call. This woman is in a lot of pain. I'm out at the house. She has morphine here in her comfort kit, but the family doesn't want to use the morphine because that's a little too much for them right now. Okay. But she can't swallow. Okay. So I called her in some liquid oxycodone, right? So at like 3, I get a phone call from the care center because the nurse had to send him over because the oxycodone wasn't enough to quell her pain. So now she is in a whole lot of pain, and she's screaming and unresponsive to everybody because she's in so much pain. So a lot of times you really have to talk to the families, and people, even sometimes it's the patients. I don't want that. I know someone who is addicted to that. Mm-hmm. But you're not taking it for fun or to feel good. You're taking it for pain, right? So we're taking it the right way. What's the difference between tolerance and addiction? Like, what is addiction?
Psychological craving.
Basically, you're going to do whatever you can to get that drug, right? You're willing to break some laws and do things that you normally wouldn't do if someone's willing to give you those drugs. So that's addiction. Tolerance is different. That just means that your body has built up a little bit of a tolerance, so it's going to take you a little more sometimes to get rid of that pain. And patients see that as addiction. Oh no, my body's addicted now. I can't go off of it because when I do, I get all dizzy. That's not addiction. That's your body. You have to taper off and whatever. So it's a lot of education with the family members and the patients as to what pain medication is, why it is safe to use it, and what the disadvantages are if you don't use it. Breakthrough. So sometimes you'll see this just written like, your oxycodone immediate release for BTP, breakthrough pain. So it can be moderate to severe periods. So let's say your patient is on 10 of Percocet every 6 hours, around the clock. But after about 4 hours, they start getting a little uncomfortable, and they're not due yet. But it's not that same acute pain that they would have if they stopped their medications completely. Or it can be super acute pain that's just sudden. That's your breakthrough pain. So usually we have something else that we can give between the around-the-clock doses. Those are your PRN doses, right? As needed. Cultural responses to pain. There's a part tomorrow when I get you guys into the library resources and Ovid. I'll show you that there's a whole section where you can go in and pick a cultural group and then put in like end of life for that cultural group. And it's going to give you like the stereotypical, and that is not saying that every person of that background is going to have that belief, but it's going to give you an idea before you walk in that room to kind of like, this might be what I walk into. And so, I don't know, it's a good resource. I'll show it to you tomorrow. But you have to be open to the cultural responses, because you're going to have people that just absolutely don't want, their pain medication, and they just don't believe in it. They're going to want certain cultures, it's, cold and hot. You're going to treat cold diseases and hot diseases and back and forth. And so you have to know, again, your population that you're working with. All right, so